Okay, let's talk about the revenue cycle. So, I 100% guarantee that all of you will have to interact with the budget process at some point, and I'm sure a lot of you will have to interact with the revenue cycle process at some point because it touches everything. So, what is the revenue cycle? Great succinct definition. All administrative and clinical functions that contribute to the capture, management, and collection of patient service revenue. That's a great succinct definition. So take a look at this, and we'll go through each area here. Okay, so and we see there's some cyclical nature of things because we may have to circle back here in a number of different ways. But it's a pretty good graphic of the revenue cycle. So scheduling and pre-registration, patient calls, I need an appointment. Provider, okay, let's get your insurance card, your date of birth, your employer, etc., etc. I'm sure we've all done that as a patient. There needs to be some kind of an insurance verification process. Make sure you're still eligible. You may need a referral to have the services done if you're in a capitated or an HMO plan, and even if you're in a PPO plan, you may need an authorization. Most PPOs require authorization for expensive things like MRIs and surgical services, right? You need authorization. Just hope it's not a retired pediatrician authorizing spine surgery, which used to drive my spine surgeons crazy to be challenged by somebody that wasn't board certified in their specialty. But that is a subject for another day. Registration, time of service. I'm here to see the Dr. X. I'm here for my surgery. Okay, you might need a copy of your insurance card, your driver's license. More and more, that's just done ahead of time, via your laptop. The last few doctor's appointments I've made, I've just uploaded this stuff. They've sent me a link. Your health history, more and more, that's done ahead of time. But you might have to sign some paperwork. Either sign electronically or sign it there. And if you have a copay, right, you're going to collect your copay. Then you see the doctor, or you have the service done. There's some kind of a coding and documentation function, right? Physician has to document the service. The institution has to document the procedure, surgery, meaning operative report, et cetera, et cetera. So there's a charge capture function based on that. In the old days, back in the 80s, as director of finance, I used to have to chase the nurses down for their charge slips. ER was notoriously bad, and I would complain. They would say, Dave, we're here to provide patient care. The emergency room is a hectic place. And I'd say that's great, but if you don't get your charges in, we won't have any revenue to keep to pay you. With modern EMRs, that just kind of happens now. So there's no young smart aleck finance people bugging the nurses for their charges anymore because it just happens as you do things. So that's a good thing. Then there's a claims processing function where the charges are actually right. They get billed to the insurance company, right? And that from there on, we're in the patient accounting system, which is a separate system from the basic accounting system that manages this whole process, the patient accounting system. The claim goes to the Insurance company, there's some kind of adjudication, they pay it, they append it, they deny it, they issue some kind of to the provider, they issue an explanation of payment. To the patient, it's an explanation of benefit. But in the common vernacular, usually people just call it an explanation of benefit or EOB either way. When I'm in a pedantic mood, I like to point out that for the provider it's an EOP, but people roll their eyes at me. So it's an EOB. It's common. It the payer is telling you what they did with the claim. Let's say the payer hasn't responded to you in a timely manner, then there's account follow up. Hey, what's going on with the claim? In a perfect world, this would be minimal. Unfortunately, it's not a perfect world. In 2000, I went down and met with state legislators to get required the workers' comp companies to pay timely, and we got a amendment to the Workers' Comp Act that they had to pay insurance. They had to pay interest on the claim if it wasn't paid within 60 days. Most states have some kind of a provision that the insurance companies have to pay on a clean claim. All the pieces are there within 30 days, or if they have to pay interest. So we got it in, I think, 2000 for 60 days, and then the insurance companies weren't doing it. And there was a quirk in the law that we couldn't sue them or chase them for that. It's a whole long story. So we went back to the state legislature a number of years later. I was the point person for the State Medical Society. I testified. I met with legislators, and it was SB 907. We got it passed. We lowered it to 30 days, and we allowed providers to sue the workers' comp companies if they didn't pay within 30 days and or pay interest. Governor Rauner vetoed it. Then I had to go back down there, and we overrode the veto. Again, the longer insurance company takes to pay the claim, the more interest on your premium dollar they get. So unfortunately, it's not always as straightforward. It's gotten a lot better over the years. But anyway, I digress. There's an account follow-up provision. What's going on? Why haven't you paid the claim? Do you need more information? Maybe the insurance company is saying, hey, we need more information. We need an operative report, etc. Okay, we get paid something, or we get it adjudicated. That gets into the patient accounting system, and maybe it's adjudicated. It's denied. Patient was ineligible, or operative. We need an operative report. The treatment doesn't match the diagnosis. There's millions of them, and maybe we have to appeal it, et cetera, et cetera. So there's a function of denial management that loops. Again, let's look at it. This dark one, maybe it should say adjudicated. I think I'll change that in the actual notes. But let's say it has to go back to one of these other pieces to get whatever the issue is fixed and then resubmitted. And then let's say it does get paid and the patient owes some portion of the money. They haven't met their deductible. There's co-insurance. Okay, so that's kind of the revenue cycle in a nutshell. Just a quick aside, if you hear these terms, in the old days, we sent claims out on paper, in the dinosaur times. And then some, you know, Blue Cross was one of the first ones we could submit them electronically. And then we came up collectively with standard file formats, so that we didn't have to have a different file format, electronic file for every different payer. So the claim submission file format is called the 837 file. That's what we submit in that format to the payer. The explanation of benefit / payment file coming back from the insurance company to the provider is called the 835 file. And the payment is rarely a check anymore. It's some kind of electronic funds transfer. These other ones are there just in case you hear them. But the what you might hear quite often is 837 or 835, and that's what those refer to. Okay, so the accounts receivable ledger. What happens? We have our charge for our MRI. It goes over to the accounts receivable ledger. It may go into the ledger at $2,000, which is the charge, or it may go into the ledger at $1,200, which is what you expect to get paid based on the sophistication of your system. We'll talk more about that in a second. But basically, these are the terms that you should know because you will likely hear these often if you have anything to do with accounts receivable. So the charge is what's in your charge master. The allowed amount is what is the contracted amount that you've negotiated with the payer or that Medicare has told you they're going to pay. The difference between the charge and the allowed amount is called the contractual adjustment. Makes sense, literal. We're adjusting it off because of the contract. So thus the contractual adjustment. Okay. The insurance may or may not pay, in this example, the $1,200. Why would they pay less than the $1,200? Patient hasn't met their deductible. Patient has a co-insurance. The insurance company only pays 80% of what the contract says. Patient pays the other 20%. Okay? So these are important terms. Please learn them and know them. We should talk quickly. If you in the executive program, if you had my 451 class, we've already gone through this. Hopefully you did. Cash versus accrual accounting. Quick summary. In cash accounting, we record our revenue as the cash comes in. So we have December activity is when this MRI was done. Under cash accounting, these transactions in December go to the patient accounting system, but they don't flow through to the financial statements, to the income statement and the balance sheet in the month of December, because we're just cash basis. So when the insurance company pays in $500, we record $500 in the income statement, profit and loss statement as revenue. We reduce our accounts receivable in the patient accounting system by $500, right? Because we've gotten paid. Our balance sheet we really don't do anything with because we're cash basis. The accounts receivable is just kind of off to the side under cash basis system. February, the patient pays the $700 that they owe. We record the revenue in February, cash basis. An accrual basis, which is going to be any institution, Our surgery centers are accrual basis. On the physician side, we were cash basis. Just a lot easier. Just that the sheer volume of transactions in a 120 person orthopedic practice, it's just simpler to do cash basis. But with the surgery centers we own, we do accrual basis. And so an accrual basis, you record the revenue in the month of activity. So in this case, we had our charge less our contractual adjustment. We hope to get $1,200. We record that $1,200 on our income statement as revenue, and we record the $1,200 on the balance sheet as accounts receivable. Again, with respect to the patient accounting system, there's no difference between cash and accrual. What we're talking here is the actual financial statements that are presented. Okay, so in January, we get the 500 on the balance sheet. We reduce our accounts receivable by $500. We increase cash. February, patient pays. We increase our cash. We decrease our accounts receivable on the balance sheet. So cash versus accrual. Okay, regardless of that, we have an accounts receivable ledger in the patient accounting system that keeps track of all these transactions. And the important thing that we'll get into in a minute is we try to age the from the date of service to the present, how old these accounts are. Super important concept in patient accounting and revenue cycle. And typically you would run this report, this summary report, by like insurance company or major category of insurance company called financial class. You can run these by doctor, if you could run them in super detail by patient. But typically I get a month end report exactly like this, basically by major insurance companies. So like for PPO, there might be 50 insurance companies that we categorize as that. But this is exactly copied from what I get every month. And we'll talk about age in a minute. Okay, so that's the kind of the accounting way of it. Now let's talk about monitoring the cycle. How do we make sure that the cycle is working well? Again, go back to the first class. I think I said I like, or the second one. I used to do some flying. I like to look at my instruments, right? So this is like being in the cockpit of your airplane and looking all your instruments to make sure the plane is flying correctly, right? Or in your car, your oil pressure and your temperature of your car. So I've done some overall reporting that you might look at. Deniable, controllable adjustments, we'll talk about that. Super important. Accounts receivable aging, we'll talk about. You might run some actual versus expected. We'll talk about that. Payer mix we'll cover. Days in AR we'll cover. Liquidation we'll cover. Percentage we'll cover. Cost to collect, some textbooks mention it. I don't think it really isn't a revenue cycle management report, but I throw it in there as a nod to these folks. And then specific to the function, again, I'm not going to test you on any of this, but if you're ever into the accounts receivable management, this is a good cheat sheet. You might to the scheduling, registration, and verification, you might run some percentage of accuracy reports, some quality audit reports. I had my training department in their downtime. they would do quality audits of registration. I would have them pick like 30 registrations per office, and just do a quality audit. Look for duplicate accounts. That's one of the awful things to have, is to have somebody in the system multiple times, because then it's really hard to keep things straight. Coding, to as far as physician coding, we had a biannual best practice is an outside person come in biannually and do coding audits to make sure that physicians are coding accurately. Charge capture, reconciling reports, timing of data service to when you actually do the charge. Surgery center world, we operative reports have to be in within 24 hours. There's always some physicians that are slow to do that. We measure the lag time, and then we get on these physicians. You got to turn in your operative report so we can bill it. Denial management, we'll talk about that. All sorts of lag timing reports, claims paid at 100% of charges, anecdote time. I think I said before, payers will pay the lower of the contracted rate or your charge. And the reason they have that in their contracts is because they know some percentage of providers will bill them less than the contract says. Why? Because providers are busy. A lot of physician practices are poorly run, and even some hospitals we run into this. So some physicians that I worked with had an interest in a surgery center. They were kind of unhappy with the financial results. They asked me to take a look. I saw surgeries that were being billed less than the workers' comp fee schedule. Okay, so let's say the fee schedule was 10 grand, the surgery center was billing 8. So the payer was paying 8. They weren't going to pay 10 if you billed 8. So I sent an email to the administrator. You've got charges less than the approved work comp fee schedule. And he sent back one of the stupidest emails or responses to a memo. He said, well, I understand that, but be happy that you're getting 100% of charges. And I think I literally said, this is the stupidest email I've ever received. If you were billing $1, you'd be getting 100% of charges. Fix it. So I actually we run 100% of charges report just to make sure that nothing slipped through the crack and that we don't have a fee that's less than a charge. You saw in the budget report or the variance report that we keyed in $350 instead of $3,500, right? We were getting paid 100% of charges. That would have shown up on that report too, the mistake we made. Okay, so all sorts of other reports. The most important, in my opinion, is the denial adjustment report. So I did a consulting project a number of years ago for a major Chicago area institution, name it. Very poorly run revenue cycle department or accounts receivable department, billing, whatever you want to call it. They had no denial reporting that fed back to fix the root cause. I don't know what to say. It still scratches my head over that one. So in other words, every month, when I was actively managing this, I would get a copy of the denials, the dollar volume of the denials we got based on the adjustment code from the payer. And there's literally, I think there's like 95 different distinct kind of adjustment codes, denials or adjustments. Why the payer adjusted this, didn't pay full contract. Why they denied it, why they didn't pay full. And you work those reports to then fix what the root cause is that's causing that denial. So a couple of examples here. If you get a denial, provider isn't credentialed, that's a never event. You go to the credentialing department. Why isn't this provider credentialed? Why is he or she seeing patients for this insurance company if we haven't gotten them credentialed to the insurance company yet? Denied for investigational or experimental. Does the physician know that this procedure is investigational or is experimental? Do we have an ABN, advanced beneficiary notice agreement, with the patient that says, that makes them aware that this may be experimental? The insurance company may not pay it, in which case you're responsible. You can't bill the patient for something like this unless they've signed an ABN. Not medically necessary. Okay, that's usually a documentation issue. The physician hasn't adequately documented the medical necessity. Okay, all these other things, no referral authorization, that's a failure of the referral authorization department. Let's get some staff education. Physical therapy benefit has maxed out. Are we tracking the benefits? Are the front desk letting the patient know you've reached your insurance company max? To continue on, you have to appeal with your insurance company and or agree to pay, self-pay. Timely filing. So insurance companies, most of the contracts, you only have Blue Cross, you have a year to bill. Medicare, you have a year. Like United, you have 90 days. So if we're getting denied because we didn't file in time, it's usually the physician isn't getting operative notes in time, and Dave is very upset. Patient not eligible. Okay, why didn't we know that ahead of time? Diagnosis inconsistent with procedure, physician education. Okay, so again, like the number one most important report, in my humble opinion. AR aging, very important report. So we're doing percent of our accounts receivable balances. What percentage of them are in these time buckets? And obviously, we want the majority of our percentage to be more current. If I get this report every month, if I start seeing these older accounts shoot up, I am not happy. I'm trying to find out why we aren't getting paid, why these accounts are quote unquote aging out, right? So that's a key. Actual versus expected payment, probably self-explanatory. This could be against last year. This can be against budget. I've got a few different ones. Mostly I do rate like per RVU. So in this example, I've done it by payer. This is an actual report. I'm looking at the average amount paid per RVU against prior year. I also do it against budget. I look at it by physician, the actual amount paid by RVU against budget. I also do prior year for physician. Just giving you some examples. Some people do percent of charges. That's kind of old school. The benefit of RVU is the RVUs are the same, across the nation. The work RVUs are, and so you can benchmark against industry standard benchmarks. Charges is strictly internal. So a little bit old school, but some people still use percent of charges. The key is that you have an expectation and you're measuring your results against the expectation, just like budgeting. Okay, just a quick aside: if you're doing actual versus expected payment, just make sure your dates of service line up. So you have a busy December, you're not going to collect that money till January, February, March. So you just make sure that you take that January, February, March money that you collected for December services, right, is compared against the services you did in December, right? So you don't want to take that January, February, and March money that related to December and compare it to January, February, and March services, right? Kind of makes sense. I think that's enough said. You just want to match apples to apples. Payer mix is really important because payers pay different amounts. Okay, so I look at this every month without fail. And so let's just give it in Illinois. In Illinois, workers' comp, typically it's surgical services is the highest payer. Not so much for not for inpatient or not for office visits. It actually pays about Medicare. But let's say for surgical services, it's the highest payer. And then you know Medicare, let's say, is the lowest. Let's say Blue Cross is in the middle. So if you have everything's exactly the same versus whatever prior year versus budget, you did the exact same number of the surgeries, the exact same type of surgeries, right? But the payer mix shifted, you could have less or more revenue. So in this example, again, in Illinois, surgical services work comp pays higher. California, I think they pay about Medicare, but we're in Illinois. So let's say everything was the same. Again, maybe it's based on last year or budget, doesn't matter. Let's just say against last year. So physicians are upset, revenue is down, counselor you're not managing, the revenue cycle department, well, they stink, they're yelling at me. Everything's the same. Same number of surgeries, same type, everything. Well, if last year 30% of my surgeries, right, were work comp, and this year they're 15, and 15% were Medicare last year, or yeah, and 20% are Medicare this year, and Blue Cross last year was 40, and now it's 48. You can see that I've replaced relatively higher paying work comp cases for lower paying Medicare and lower paying Blue Cross. So my revenue is going to be down. So this is super important, and you're going to have some assignments based on this. That's why looking at payer mix is really important, because everything can be exactly the same, but the patients switch from a higher paying insurance to a lower. And I, I the most common one I've seen is in my career is Blue Cross rate is the percentage of Blue Cross patients has dropped and the percentage of Medicare has gone up, especially in orthopedics with the aging baby boomers. Okay, gross versus nets accounts receivable. So old school. So here's what happened in the past when we had that service, right, and we and the charges went to the accounts receivable ledger, we know we're not going to get paid charges. So we had to take account when we're valuing that accounts receivable ledger and how much we actually expect to collect. We had a two-step process. We have to try to estimate the contractual allowance, which is the contractual discount. And then we had to kind of estimate the bad debt, which is just it's owed, but it's not going to get paid. And so to get from gross to net, what we actually truly think we're going to get paid, we had to make an estimate of contractual allowances and an estimate of bad debt to get to net. So gross less contractual less bad debt. In the modern systems, the accounts receivable ledger, the modern billing systems have the sophistication to actually determine what's going to be paid and to take that contractual allowance adjustment at the time of billing. So the ledger reflects that contractual allowance discount, and we just have to do some bad debt estimation. So this is I don't want to go too much in the rabbit hole, but the you know especially in surgical services, determining what you're going to get paid is not as straightforward as you think. Let's just say it's a colonoscopy and you're removing a polyp. So let's say the contract says whatever, you get $500 for a polyp removal. If you do, so you remove a polyp, you get 500. If you move a second polyp, you don't get the same 500 bucks. There's a 50% reduction, which is standard. So you only get 250 to remove the second polyp. The third one, you get paid 25% of the allowed. So you only get 25% of the 500. The logic being, you've done everything you need, for the most, you've done 80% of the work to remove the first one. The second and third one aren't as much work, right? That's the logic. Same thing with spinal fusion, et cetera, et cetera. Same thing with rotator cuff surgery with a bicep tendinosis, right? So anyway, not to go down that rabbit hole, the billing systems on the provider side just weren't as sophisticated to do all that work for you. So you had to kind of rely on the payer to tell you. You had to rely on, there were third-party systems that did this. I actually wrote a spreadsheet that did this. I called it the Kanzler-O-Matic, that actually computed this if the patient accounting people wanted to know. So anyway, sorry for the rabbit hole. For our purposes, we're gonna just kind of look at modern systems. So, but why this is kind of important and why I kind of make the distinction. So our good friends at Edward Elmhurst a number of years ago had a $92 million accounting error. So they loaded in Epic. They, again, sophisticated system, could take the contractual adjustment at time of billing. But they made two mistakes. They loaded the contracts incorrectly, which was we just implemented one of these last year for our surgery centers. Prior to that, we had old school, and this is what kept me up at night, loading the contracts incorrectly. And they didn't do an aged AR analysis, which we're going to talk about in a minute. So there were two mistakes they made. So what's an aged AR analysis? So we look at the age of the accounts. The older they get, the less probability of collecting them. That's bad debt. So the older they get, right, less likely people pay their doctor bills and their hospital bills. I think it's last on the list if they're right struggling financially. So in the industry standard is to fully reserve the accounts over 180 days. So what that means is for accounting purposes, we still try to collect them, but we're pretty much reserving them at 100%. We're for accounting purposes, we don't think we're going to get paid. That's kind of an industry standard. In my opinion, had Edward done a proper aging, they would have caught this issue much sooner than they did. So what they were doing is they loaded the contracts in wrong. It was overvaluing what their revenue should have been. However, and it wasn't doing a proper aging, because if they'd done a proper aging as these accounts got older, they would have written those accounts off and taken a hit. Okay, don't get too caught up in the accounting. Trust me on this. But let me show you how that's done. So, so let's assume we have a modern system. We've taken the contractual adjustment at time of billing like they were supposed to, and remember that that bad debt is the difference between the AR less the contractual less the bad debt reserve is net AR. So the difference between gross and net is bad debt. So here it is in a nutshell, and this is exactly the kind of stuff that I do every month for my 5 centers. So the system gives me a report that says here's the accounts receivable balance, and it's net of the contractual adjustment. This is what we should get paid by contract. And then what I do is I have aging factors, and these aren't the actual ones I use. I'm exaggerating the reserves for illustrative purposes. But let's say through 90 days, I'm going to value a dollar as a dollar. Accounts over 90 days, I'm kind of taking a 25% discount. Accounts over, and again, not for accounting purposes, I'm not giving patients a discount. Over 120 to 150, I'm valuing them at 50%. Over 150 to 180, I'm valuing at 25%. And over 180, I'm using industry standard. I'm valuing them at zero, except for work comp, which takes forever to get paid. So I'm gonna keep them valued. So I take the gross AR times the aging factors to get my net AR. And so I have 7.1 that should be paid, but since patients don't pay their bills, healthcare bills, as readily as they pay their cable bill or their cell phone bills, I'm going to say I only expect to collect 5.4. And again, this is exaggerated for illustrative purposes. And so the difference between the gross and the net is my bad debt reserve. So this is what I think my reserve for bad debt should be. Okay. So the hard part is determining these numbers based on experience, time, etc. So one of the things I do, this is a little down the rabbit hole, but I think it's worthwhile covering. I do an annual AR liquidation study. I actually do it semi-annually, but I do it annually for the auditors. So at the end of the year, so the value of the model is this model right here. At the end of the year, I record, put this in a spreadsheet. My initial run date is the 14th of the following, let's say January 14th, and that's just when we close December posting. So it takes a couple weeks to post all the charges in the system, right? So I ran my data on January 14th because that's how long it took me to get all the payments posted for the end of the year. Okay, and then I rerun it in July when the auditors are in asking me to for this kind of report. So my gross AR is the 7.1. This is an actual spreadsheet I use. The data is illustrative, it's not actual. Per my model is 5.4. There's my 5.4 there. Okay, so my net to gross is 75.9%. Okay, so then on the 14th, I say, let's look at date of service collections, everything I've collected for dates of service. I go back 3 years, January 1st, 22. I guess this is, yeah, all of 22, all of 23, all of 24. So for those dates of service, at as of January 14th, I've collected $6.7 million, right? And again, illustrative purposes. Then auditors come in, they want to validate my 5.4 million on the balance sheet. I run collection report, same dates of service, January 1st to 22nd through 12/31 of 2024, but I run it as of 7/15. So I'm looking for these dates of service. And in this case, I've collected $11 million. So I've collected an extra 4.2, 4.3, let's call it, $1 million for those dates of service. I compare that to what I said I would collect, 5.4, and I see that I'm $1.1 million short, having what we call it a run out, 6.43 months of run out. So in this case, my model is probably too liberal. I'm probably overestimating the value of my AR. So I have to adjust these factors. Okay, so if it's a negative number, I'm short, it's probably overvaluing. Now I would run this again maybe at the end of the year to capture those work comp claims, but if I'm this far under after almost 7 months, I probably got a problem. So I'm comparing its liquidation. I'm comparing what I've actually collected against what I thought I would. In this example, let's say this everything's the same, only I collected $13.5 million. So I've collected $6.7 million more than I had at the end of the year for that same date of service. I predicted 5.4. So now I've collected 1.3 more than I predicted. That model is probably my model is too conservative, right? I need to change my factors. And this is exactly what I've done over the years. Exact same thing. I've done it twice a year. Let's say just right. So let's say the same thing, everything's the same except I've collected 12.1 million, 12,160,000, So I've collected 5,441,000. I predicted 5.440. That's pretty good. Now I'm gonna, again, the longer if I run this again in another 6 months in Illinois, because workers' comp takes so long to get paid, you know, this number is going to go up a little. But this is kind of the way I test the model. Okay, for most of you, you know, you're probably getting glazed over, but just to show you how it's done. Okay, so what is the one of the most common reports, and that's the average days in receivables. It's a great number because it's a good snapshot metric. You're going to have this in the homework. You're not going to have any to do with liquidation. So average days in receivables. If your AR is at charges, old school, you take your accounts receivable balance divided by your average daily charges. So you match up the time period. So if you're looking at a 180-day metric, you take 180 days worth of charges divided by 180 days to get your average daily. You divide that into the AR balance. It tells you the average time it takes to adjudicate your accounts receivable. If you're modern and your accounts receivable is net of your contractual allowance, like most systems are now, you take your accounts receivable balance and you divide it by your average daily net revenue, which is, again, you just have to match up the time periods. So you would take, if you're 90 days, you take 90 days of revenue divided by 90 to get average daily. It takes the average time to collect. Little pedantic here. If your ARs are charges, technically we're measuring the time it takes to adjudicate, which is the contractual adjustment and the collection of what's owed. If your AR is already taken your system has already taken the contractual allowance at time of billing, technically you're measuring the time it takes to collect. So I'm being a little pedantic, annoying person who at a conference will make a distinction. For our purposes, we'll just say it's the average time it collects because I'm giving examples in modern systems. So you're going to get this in the homework. Again, key to the homework is looking at the lecture notes. So let's say our gross accounts receivable, we're going to do one at gross and one at net. Old school, modern. We have accounts receivable balance at gross is 6 million. We're going to do a 3-month measurement of our average daily. So we take 3 months of charges, we divide it by 90, and then we take our average daily charges would be 77,778, and we divide that into our $6 million AR balance, and it's on average it takes us 77.14 days to adjudicate, or we'll just say collect. If we did that at 6 months, we would take 6 months of charges, we would divide that by 180 days, and our metric would be the AR balance is the same, that doesn't change. 6 million divided by that 85.56 gives us 70.13. And the difference between 90, it used to be 365 was kind of the standard, but the reason it's gotten shorter is because the seasonality. We kind of mentioned that in budget spread method. With the increase in patient deductibles, it used to be $500 was a big deductible. Now it's $5,000 is kind of standard. People are putting off care till later in the year. So it used to be care was kind of spread evenly through the year. So 365, 180, what difference did it make? But now, if people are putting off care to the end of the year and providers are busier at the end of the year, now if you use 365, you're averaging that down. You're not getting a good you're not getting current events to take a phrase from the movie Aliens. You're not keeping up with current events. If we do net, so let's say our accounts receivable is at net. We have 1.5. We use revenue instead of charges. So that's 101.8 million. We divide it by 90 days. We get $20,000 a day. 1.5 divided by 20,000 a day, 75 days. So it's a measure of how long it takes you to collect your money. If we did 180, obviously our revenue would be more because it's a longer time period. We divide it by 180. The metric is 22,000 days in AR 68. Okay, there's the formulas for doing the homework. Pretty straightforward. So it's a really good snapshot on how long it's taking. It's like one of the number one metrics that people use. How long does it take you to collect your money on average? Super important. Okay, we're gonna wrap up. We're at an hour, and we're gonna go to a second video that's kind of the application of these principles.